Yeah, okay, thank you. Thank you for having me. I'm Herman Botero, and I'm a hip and knee replacement specialist in Knoxville, Tennessee. And a special thank you to Dr. Silvestre for inviting me for this meeting and allowing me to talk about a topic that I have interest in. Just a quick disclaimer, I am currently in Guatemala serving on the medical mission, and there is a loud parrot right outside my window, so hopefully he cooperates for the next 10 minutes or so. So I'm going to be talking about cemented femoral stems, modern indications and outcomes. And we've been doing cemented femoral stems in hemiarthroplasty since the 1950s. Pioneers like Mueller, McKee, Watson, Farrar, and Habish started that all over the world. It wasn't until the 1960s when Sir John Charnley really popularized it with the use of cemented hip replacements. And since the 1950s, cemented femoral stem design and specifically cemented techniques have evolved dramatically. And over the last several decades, we have seen that cemented femoral stems have well-documented, excellent long-term outcomes. However, there's been a shift to cementless press-fit femoral stems that began in the 1980s. This came about because we felt that there was a need for biologic fixation for younger, more active patients. We were also seeing the problems of aseptic loosening, which was incorrectly attributed to cement. We now know that that was really due to debris from wear. And as we started using more and more cementless femoral stems, we liked the fact that it was quicker surgery. We didn't have to wait for cement to cure. And there was also the fear of bone cement implantation syndrome. And so cementless femoral stem fixation continues to rise worldwide. In the US alone, we are press fitting stems in over 90% of elective hip replacement cases. And the problem with that is that we're using press fit stems in the patients who are at most risk for complications, the elderly patients over the age of 80. We're using cementless fixation in over 50% of them. The problem with this, aside from the increase in complication rates, is that we have a generation of surgeons with very limited experience using cemented femoral stems, and that just helps perpetuate the problem. So looking at national registries, here's a study looking at 7 national registries from all over the world. What are we seeing? We're seeing an increased use of cementless stems in many countries like Norway, Sweden, Denmark, where they're using 71% of their hips are cementless. And then we're seeing some that are decreasing in use. So maybe these countries are getting it right: Australia, England, New Zealand. What all registries are showing is that in patients over the age of 75, the outcomes were significantly better for cemented femoral stems, and that's in all registries. So it's important to know the different modern stem designs, and they're divided into 4 types. And we're really just going to briefly touch on types 1, 2, and 3, which are the ones that are most commonly used throughout the world. And again, all of these cemented stems have very good outcomes. The type 1 stem is the polished, collarless, taper stem that when you broach, the broach is about 2 millimeters larger than the implant itself. And so you are leaving a 2 to 4 millimeter cement mantle. This type of stem can subside over the course of the first year or two, about 1 millimeter or 2. And that's part of it, the fixation technique that makes it successful. The classic example of this is the Exeter stem. Excellent survival rates in the National Joint Registry in England, over 98% at 20 years. Even in younger patients, 98% at 17 years. Of course, with cemented stems, the most common mode of failure is going to be aseptic loosening, but again, with very long survival rates. One thing to be aware of with this particular stem type is that recent data is showing some concern for higher rate of periprosthetic fractures, which was just mentioned in the previous talk, when compared to the type 2 stems. And these are in patients who are older with frail bone. Type 2 stems are stems that are rounded, have a round shoulder, and typically a collar. These are not polished typically. They're more matte finish. This was based on the design by Charnley. These stems are also broached but can be reamed. And you also have that 2 millimeter or so cement mantle. Also, excellent survival rates, 94% at 20 years, multiple registries showing that. The Charnley low friction stem, survivorships of 80% at 35 years. This stem is widely used in the United States when we get it right and we actually use them. And they have very low rates of periprosthetic femur fractures in the elderly and frail, outperforming the type 1 stems. Type 3 stems, widely used in Central Europe. This is a taper type stem. It's really, the technique is different. It's closer to the technique that you would use for a press fit, which is why it's a line-to-line technique, also known as the French paradox. The cement mantle here is only about 1 millimeter, and in some areas, there is no cement mantle. Excellent survival rates throughout the registries, 94 to 98% at 15 years. Also excellent, very good survival rates in the younger patients, less than 50. One thing to consider here is that this particular stem design is an excellent option for the femur dorsi femurs, which are those wide stovepipe femurs that have no cancellous bone, where you would fill that metaphyseal with the stem and then use it as a line-to-line technique. Very low rate of periprosthetic fractures. So again, registry data remains strong with regards to survivorship outcomes of cemented stems. The results are equivalent or better in ages greater than 75. There might still be some controversy with regards to the younger patients, but Fetty and al. Did a meta-analysis, 27 studies, and the results in terms of survival and equivalence in the young and superiority of cemented fixation in the older patients. What's not a controversial topic is this problem here, the femoral neck fracture. Cemented femoral stem fixation is the gold standard when treating geriatric femoral neck fractures. There is an abundant amount of strong level 1 data globally establishing this. And I'm not talking about, the 55-year-old cyclist who had a high energy femoral neck fracture. We're talking about the frail elderly population, low energy, fall from a standing height, osteoporotic fragility fractures. The National Institute for Health and Care Excellence in their hip fracture management, they strongly recommend cemented implants for patients undergoing arthroplasty for femoral neck fractures. Here's an article from the Bone and Joint Journal. Again, looking at cemented versus cementless for femoral neck fractures. 5 randomized controlled trials. Again, level 1 studies, 950 patients. What did they find? Well, of course, the cementless stems, shorter surgeries, about 10 minutes shorter, no difference in mortality. But the key here is that cementless stems are associated with more complications, especially implant-related periprosthetic fractures. Here's another one out of the Bone and Joint Journal, looking at effectiveness, safety, cemented versus uncemented. 18 randomized control studies, over 2,800 patients. No significant difference in mortality up to 1 year. Cemented stem fixation obviously increases operative time. We all know that, but it's safe. And what we found is the contemporary cemented stems substantially lowers intraoperative and postoperative periprosthetic fractures. Here's another one. This is from the best journals in medicine, New England Journal of Medicine, not even an orthopedic publication. Randomized controlled trial, cemented versus cementless. This is a very key article because not only did it show lower incidence of periprosthetic fractures, but it showed improved quality of life based on the EQ-5D utility scores at 4 months. Why? Because cemented stems are immediately stable. And so these older patients don't have thigh pain. They mobilize quicker with this fixation type. Here's a large study from the US. This is Brian Springer's group from the American Academy of Orthopedic Surgeons, over 17,000 cases. These were all matched to age, sex, BMI, and comorbidities. What did they find? Cemented stem fixations were associated with 30% reduction in all-cause revision 90 days, 30% reduction in revision at 1 year, and an 86% reduction in revisions for periprosthetic femur fractures. The Dutch registry, they cement most stems over there. What do they see? They see that the survivals are equal when you compare cemented versus uncemented, but the revision rate significantly increased in the uncemented stems. In 2014, the American Academy of Orthopedic Surgeons put out their evidence-based clinical practice guideline. This is important in the US because from our healthcare system, Medicare, we have to follow these to make the best decisions, which are for the best outcomes for patients, but they also have significant cost implications. So in 2014, the practice guidelines only had a moderate strength recommendation for the use of femoral stems for femoral neck fractures. Fast forward over the last 10 years, the strength of the data in all of these randomized control trials clearly led to a strong recommendation for strong evidence femoral neck fractures in the elderly should be treated with cemented femoral stems. So, cemented femoral stems, fixation, long history, success globally, continues to be an important option for hip surgeons and their patients. Numerous studies and registries show survivorship outcomes that are equivocal to cementless stem fixation and outperforms them in the elderly population. But despite the favorable data, cemented stem fixation remains underutilized in many areas in the world. Knowledge of the cemented stem type and cementing technique is critical to achieve these excellent outcomes, but we also have to change surgeon behavior, and they have to focus on the data. There is no question that cemented stem fixation is the gold standard for the treatment of femoral neck fractures in the elderly, low energy, and osteoporotic patient. Thank you very much.